Thank you very much for the kind introduction, and Harry and his team that he organized that so well and invited me to this prestigious conference. In the next 15 minutes, I will give a short overview on mediastinal cryobiopsy. And if we think about mediastinal lymphadenopathy, we can order it in two main categories: malignant causes and benign causes. And most often we have the question when we have large lymph nodes whether it's a metastasis. And as Felix already pointed out, for metastases in the guidelines, EBUS-TBNA or EUS-TBNA is the first choice for tissue sampling. So what is with other primary cancers like lymphomas, myeloma, and leukemia, or benign causes? And we know from studies that with EBUS-TBNA we can make the diagnosis, for example, of sarcoidosis. And in this review here, the diagnostic yield was between 79 and 92%. So we don't have in all cases the diagnosis. And furthermore, we don't have in non-small cell lung cancer in all cases enough tissue for molecular genetic testing in the studies published so far, and it depends probably on the center, but it was between 20 and 40%. You can't do that at EBUS-TBNA samples. And why is that? The reason for that is that we have small tissue samples and few cells, and the question is cryobiopsy here helpful? And if you talk about cryobiopsy, that's a transbronchial lymph node cryobiopsy, that's a sarcoidosis patient, that you get an impression how it looks like. The first paper published on this technique was published from Zhang. He had a patient with a mediastinal mass, and he couldn't get into this mass with another technique. So he performed a bronchoscopy with local anesthesia and midazolam. He used a 22 gauge needle and did 4 passes, and additionally he created a tunnel to the lymph node with an electric needle knife. He took 2 biopsies, and he had a freezing time of 15 seconds with a 1.1 cryoprobe, and he could make the diagnosis of a seminoma. Shortly after, there were the two main studies published from the same group. The first study was a study when they did a cryobiopsy and a TBNA in a randomized sequence. And they compared these two groups. They biopsied all lymph node stations, mainly for R and 7, but also the other lymph node stations. And it was quite well balanced between the both groups. And there was a significant difference in the diagnostic yield. 80% for the TBNA group and 92% for the cryobiopsy group, and that was statistically significant. Why was that? If you go into more detail, we had no difference in lung cancer patients. It was 66% in both groups, but there was a difference in lymphoma and benign disorders, mainly sarcoidosis and tuberculosis, and these differences drove the statistical significance. They had only minor bleeding, 2 pneumothoraces, not requiring a tube on 1 pneumomediastinum, also no intervention needed. Shortly after that, they published another study in Lancet Respiratory Medicine in 2022, including 297 patients, and 271 patients were enrolled. They compared 2 groups, either only EBUS-TBNA or EBAS-TBNA followed by cryobiopsy with the 1.1 millimeter probe. Again, almost every lymph node station was punctured, which is accessible with EBAS, and again, we had the same result. The definitive diagnosis was 81% in the TBNA group, and in the combined group was 93%. The procedure time was, of course, somewhat longer with the cryo group, and they had a few pneumothoraces and pneumodiastinoms. Interestingly, there were 4 pneumothoraces after EBAS-TBNA, and not only in the combined group. And as shown in the first study, the difference was driven mainly by lymphoma and by benign disorders. Lung cancer staging, there was no difference. Then let me address how they did it. That's different from center to center. They used an electric knife for tunneling. Then they introduced a 1.1 probe. In this study, they froze 7 seconds once. Let me show you a few other studies. That's a study from Hari here from Hyderabad, and he described 4 cases, and he described for the first time a tunneling technique with a needle. He froze 3 seconds and used a 1.1 probe. He didn't describe complications, and he was successful, and he could make the diagnosis in all cases, but we have to be honest, with the TBNA, we had also the diagnosis in all cases. The study from Arisa from Spain, he used also the tunneling technique with a needle. He took 3 biopsies and froze 4 seconds. And again, it was much better in the lymphoma and benign conditions, but he also had more often metastases detected in lung cancer than with the cryobiopsy compared with TBNA. But we have to admit that 78% diagnostic yield or sensitivity for EBAS-TBNA in lung cancer is quite low value. There's also one study which didn't show a difference. That's a study from JURGEN. He published 24 cases. He used a Procord needle with 4 passes, and he additionally used, if he couldn't pass the tunnel, a neodymium YAG laser to tunnel, to create a tunnel. He took 2 biopsies, in 18 cases with the 1.1 probe and in 6 cases with the 1.7 probe. Most cases, as you can see here on the right side, were sarcoidosis and cancer. And in this cryo, he had a 1.1. He was diagnostic in 88%. With the 1.7, all cases were diagnostic, but there was no difference between TBNA and the cryo. And in fact, once diagnosis was missed by TBNA, and cryo made the diagnosis, and vice versa. And finally, the last study, the latest study published so far from our Swiss group, we collected 138 patients, and we had the same results as the Chinese and Heidelberg group. In lung cancer, there was not a difference between needle and the lung cancer, but if you look at the non-definitive diagnosis group with the TBNA, they switched to the benign disorder in a relatively large proportion. Let me go to a further point. So that was the first study we published on cryobiopsy as it's used today. And because we had the experience that cryo extraction was not very popular, we thought to use a very interesting title, and we called it The Use of Traditional Cryoprobes. That means a cryobiopsy in the age of molecular biology. We didn't know that time that this may be relevant in the future, to be honest. That's two case reports, one of a Japanese group. They couldn't make the diagnosis of this nodule here. Then they started to use a mediastinal forceps biopsy, but you can see here the squeezed tissue, and additionally there was, and in this case further analysis was not possible, and then they used a cryoprobe, and then they could make the diagnosis, and immunohistochemistry was much better possible, and it was a sarcoma. That's a case from Winterthur. That's a patient with ECOG3. You couldn't go for chemotherapy, and we didn't get any tissue for molecular genetic testing in this patient. And so we did a cryobiopsy, and he had PD-L1 of 100%. And that's in line with the data which are published in the Lancet Respiratory paper from FAN. They described out of the non-small cell lung cancer patients, they could make the diagnosis with cryobiopsies in NGS testing in 97% of the cases and in 79% of the samples with the EBAS-TBNA. So it seems that cryobiopsy may be superior here, but that's not proven. So these studies were summarized in systematic reviews and meta-analysis, and I show you one of these systematic reviews and meta-analysis. The design, to be honest, is only 2 randomized controlled trials. Then we have some prospective trials, and then then we have a case series. The sedation was also different. Some used general anesthesia with laryngeal masks, some used moderate sedation, and some used a tube. And finally, the tunneling technique was different. Mainly in the randomized trials, they used an electric knife. In the other studies, it's usually that they created the tunnel with a TBNA needle. So the needle which was used was also different. Usually a 19 gauge needle or 22 gauge needle was used, and the number of passes also differed, ranging from 2 to 7. For the cryoprobe, mainly the 1.1 probe was used. 1 to 7 biopsies were taken, and the average freezing time was 4 seconds. But that was also different from center to center. And in fact, we have no comparative trials. We don't know what's the best. But taking these together, the diagnostic yield of the cryobiopsy was better than with EBAS-TBNA. And in the funnel plot, there was no hint that we had a selection bias with these studies. The other meta-analysis showed also this advantage of the cryobiopsy, but the third meta-analysis claimed that we don't have enough data yet to make a distinct suggestion. So in these 3 meta-analyses, it was described quite nicely, and I think that's true, that benign and possible lymphoproliferative diseases are better diagnosed with the cryoprobe compared with TBNA. Moreover, and that's also clear, that we can more accurately classify lymphomas with a cryoprobe than with the EBAS-TBNA, especially in Hodgkin's lymphoma. It may be also that cryobiopsy is superior, but that's not proven in molecular genetic testing of lung cancer. Coming to the complications, we have, they had only few complications described, pneumothoraces and mild bleeding, nothing relevant here, and no intervention needed so far. But that's not in the English literature. That's a German case published in Pneumology in 2023. That was a cryobiopsy sample. That was a patient. They punctured this lymph node. and the patient developed a severe hematomediastinum, and luckily he survived their vessels, and they probably hit these vessels. So it's a technique, and not a lot of complications, relevant complications were described so far, but there may be complications if you do it in the wrong way and you hit vessels within a lymph node, or if you are not very controlled where your cryoprobe is when you take your biopsy. So in these meta-analyses, they say it has proven to be safe and is safe. I think you have to be cautious to state that in this way, because we don't have a lot of data and we don't know whether there will be some additional complications in the future, and for sure you can harm the patients if you don't do it in a proper way. Finally, I want to compare the forceps with the mediastinal forceps with the mediastinal cryo, and that's a series from India. They compared the EBS-TBNA, EBS-TBNA plus cryo, and EBS-TBNA with forceps, and forceps in 34 patients, and they didn't see a difference in the diagnostic yield. However, the power of this study was fairly small. Another study published by JURGEN in pulmonology, they evaluated 155 patients. They did a EBS-TBNA followed by forceps biopsy or by cryobiopsy. If you compare TBNA plus forceps and TBNA plus cryo, there was no difference between the groups. If you compare forceps and cryo alone, there was a difference in favor of the cryobiopsy. And additionally, as mentioned previously, cryobiopsy was superior in the molecular genetic testing. So let me summarize. EBS-guided mediastinal cryobiopsy seems to be superior to EBS-TBNA in the diagnosis of lymphoma and benign lymphadenopathy. It seems to be equivalent for staging of lung cancer, molecular genetic testing, if necessary, and that has to be sure, is probably more often possible. We have rare complications, but we had one report of a mediastinal bleeding, so we have to be careful what we do, avoid vessels, biopsy on the bronchial side of the lymph node, and so on. And probably we don't know all complications which may be detected by the published data so far. So additionally, I want to mention, I think really that we have not sufficient data so far, and further studies are needed, especially addressing the patient selection, the complications, and the technique, including the mediastinal cryobiopsy via the esophagus. Thank you very much for your attention.